trace element impairment, that is if you have some changes in magnesium level in your body, and that can cause different changes that can be in the form of electrolyte impairment, when there's some systemic manifestations, and including cardiac and neurological manifestations. So what we eat is we have different elements in our food, like protein, fat, carbohydrate, trace elements, and some minerals and salts. So these minerals and salts have a very important role to play in your body. Magnesium is one of these salts, which has second most abundant intracellular cations and serve as a cofactor more than 300 enzyme reactions which takes place in the cell. Especially they involve the activation of ATP molecules. They are under the influence of magnesium. So it is very important electrolyte which is intracellular, and there is a proper function of the sodium potassium exchange pump which takes place around the cell membrane, and that generates the electrical gradient across the cell membranes. So the magnesium is an intracellular cation which has a very important part to play in your cell metabolism. It also regulates the movement of calcium into the smooth muscle cells. That is, if you have a cardiac contractile stent, especially if you have a upstroke of cardiac activity, and that is the through calcium channel, which is very important based on the magnesium in the cell. So magnesium balance, the average size adult contain approximately 24 gram of magnesium in the body, and most important of this is found in the bones, which is almost if you take a person of 70 kilogram, so you will find bone contains 12 kilogram of the body weight, muscles they contain 30 kilogram of the body weight, soft tissue around 23 kilogram body weight, and RBCs and plasma cells. Out of these, if you look at the magnesium level, that is going to be 0.03% of your body weight, which has a very important cations in intracellular. So it is so important that serum magnesium level is a favored over plasma for magnesium acid. If you ask somebody to check the serum magnesium level, you will ask for serum magnesium level along with calcium. So magnesium and calcium, they have a very important part to play, and magnesium can be found in ionized form about 67%, and remaining, which is 33%, which is bound to plasma protein and in the chelated form. Spectrophotometry is a measure you can get all these ionized and unionized, which is a protein based, protein coated magnesium levels. What happens when you take excessive amount of magnesium in some foods, that is nuts and other fruits which are rich in magnesium, and it is your plasma level which is maintained at an optimum level. So kidney has a very important part to play for maintenance of this magnesium levels. If you take excessive amount of magnesium in your foods, kidney, they will let the magnesium lose through the kidney through a balance. So if we have this is a simple graph, and magnesium intake is deficient, the kidney tries to conserve the magnesium, and if you have a excess magnesium in your food, the kidneys will let the magnesium pass away and maintaining a normal plasma level. So if we look at the plasma level, if you have a high plasma level, you have a excessive amount of urinary excretion through the kidney. And if you have a lowest plasma level, you will find a very small amount of kidney which let the magnesium to pass away. So this is a very good balance of the kidneys to play a role in maintaining your magnesium normal levels. If we look at the different range of magnesium, total ionized and ionized magnesium, which is normally found in 1.7 to 2.4 milligram per deciliter, and ionized forms in 0.8 to 1.1 milliequivalent per liter. So urinary migration is according to the plasma concentration, and it is a maintenance of normal magnesium levels. So what happens when this intercellular cations is deficient in your body? So that is called hypomagnesemia, and the patient will have a 65% of people who are having low magnesium, they are usually ICU patients, because ICU care is a very important part of hospital care, especially people who are on ventilators, who are comatose, who are having ICU care. They usually are deprived of these trace elements, especially the calcium, magnesium, copper, zinc, and they are the very important factors to play a role in the recovery of a patient in ICU care. And the potassium, magnesium maybe depletion may be noted. Sometimes it is usually hypomagnesemia is accompanied by hypocalcemia. So magnesium deficiency is the most underdiagnosed electrolyte abnormality in current medical practice. So many patients who present with even generalized tonic-clonic fits, they have a hypocalcemia, and usually you will find they have hypomagnesemia at the same time. And whatever you correct the calcium, until unless you correct the magnesium level, they are not going to have a normal calcium level. So magnesium and calcium are very important electrolytes to be maintained for a normal function of brain and cardiac electrical activity. So what are the factors which can lead, as I told you, the patient who are in ICU care, they have very fixed amount of feed, especially NG feed, or some patients are on total parenteral nutrition, and they are given proper electrolyte balanced diet by checking their daily basis sodium, potassium, calcium, magnesium, copper. Their blood sample is taken, sent to the lab, and they replace the food according to these electrolyte impairment. But in general practice, in ICU care, patient on NG feeding, they are given some food supplements like milk and other food supplements. They usually become deprived or deficient of these factors, especially electrolytes. So what are the drugs which can precipitate the deficiency of magnesium levels? Diuretics, especially furosemide. Many patients who comes with pulmonary edema or fluid overload, they are given furosemide, and 50% of hypomagnesemia is usually because of this furosemide, that is a loop diuretic. And the second antibiotic, aminoglycoside, gentamicin, and these are the drugs which can also cause hypomagnesemia. Amphotericin, which is given as antifungal drug, and pentamidine, digital digoxin is another cause of hypomagnesemia, and cisplatinum, cyclosporin, these are the drugs. So some diseases, especially diarrhea, which is secretory diarrhea, especially involving the lower GI tract, and that can cause excessive loss of magnesium from the body along with potassium and other electrolytes. Alcohol abuse, especially people who take excessive alcohol consumption, especially who have a delirium tremens, they have a withdrawal symptoms, they have a magnesium deficiency. Diabetes and acute myocardial infarction. Some studies have shown that patients who have acute MI, they have a tendency to become hypomagnesemic. And some electrolyte abnormalities, especially hypokalemia, hypophosphatemia, hyponatremia, hypocalcemia, these are associated with hypomagnesemia. And cardiac manifestations, I told you, acute MI, arrhythmia, digital toxicity, and hyperactive CNS syndrome. Some patients with fits and myoclonic jerks, they have hypomagnesemia. So these are all causes, either iatrogenic through some loop diuretics, some antibiotics, some digitalis, or some diseases or alcohol abuse can lead to hypomagnesemia and have a clinical manifestation of this electrolyte impairment. So if we talk about individually diuretic, especially People who are on diuretic therapy long-term basis, they are usually deficient of magnesium. And a urinary magnesium excretion is most pronounced, especially with loop diuretic, which is furosemide and ethacrylic acid. So these are the drugs which can lead to tubular loss of renal tubular loss of magnesium, and 50% of patients who are receiving chronic furosemide therapy, they are found to have hypomagnesemia. So be aware of patients who are patient of heart failure, patient on nephrotic syndrome, patient with the cirrhosis of liver, or patient with the fluid overload through any other cause. They are on furosemide and they can have clinical manifestation of hypomagnesemia along with the underlying problem. Second diuretic which is commonly used is thiazide diuretic, which can also have a tendency for magnesium depletion, especially in the elderly patient. The people who are elderly, they have a high tendency of getting hypomagnesemia if they are on thiazide diuretics. And magnesium depletion usually with potassium sparing diuretic like spironolactone does not cause hypomagnesemia. So usually in clinical practice, we use a combination of drugs like furosemide with spironolactone, that is in the form of spironolactone, that is a combination of potassium-sparing diuretics and with the loop diuretic that helps in preventing the long-term use of diuretics and does not worse the magnesium levels. So combination of loop diuretic and potassium sparing like spironolactone is a better choice rather than individual one drug. Second, antibiotics, we talk about aminoglycoside, amphotericin, pentamidine. These aminoglycoside actually block the magnesium reabsorption in the ascending group of Henle. So this is a renal effect of aminoglycosides. Patients who are aminoglycoside like gentamicin and other these drugs, they are usually monitored every third to fourth day of the renal function because they can have nephrotoxicity and magnesium reabsorption problem. Hypomagnesemia has been reported 30% of patients who are receiving aminoglycosides. So after loop diuretics and aminoglycoside are the another cause of hypomagnesemia through kidney loss. Other drugs, we have seen PPI very common in factors in peptic ulcer disease and reflux diseases. They can be associated with hypomagnesemia if they are used on a long-term basis. So PPI very common in practice. Every patient with gastritis, with gastroesophageal reflux, or some other peptic ulcer diseases, they are given proton pump inhibitor like esomeprazole, pantoprazole, and these kind of drugs, if they are given for long term, they can cause hypomagnesemia. Other drugs like patient with heart failure, you are patient on atrial fibrillation like digitalis, epinephrine, and chemotherapeutic agents like cisplatin and cyclosporine, they can be a precipitating factor or iatrogenic effect causing hypomagnesemia. So alcohol, very common problem in the western part of the world because hypomagnesemia is reported in 30% of hospital admissions, alcohol abuse, especially patients who present with delirium tremens, who have withdrawal symptoms of alcohol intake, and they are in a confused, disoriented after alcohol intake, and they have a usually they have hypomagnesemia. Another association of magnesium deficiency is usually thiamine deficiency. That is another association of hypomagnesemia with thiamine deficiency. And if you have a patient who has a thiamine deficiency, you need to give transfusion thiamine. And these are the patients who are also given thiamine pyrophosphate in combination with magnesium. So diarrhea, especially secretion of secretions from the lower GI tract are rich in magnesium. So if you have a diarrhea, especially toxic diarrhea, that is going to affect your large gut and watery stools are being passed, and you have a hypokalemia, hypomagnesemia, and other electrolyte loss to the GI tract. Upper GI tract are not rich in magnesium, so it is the lower GI tract which is causing colitis, and enteritis, they are the cause of like secretory diarrhea are the cause of hypomagnesemia. Diabetes itself, we call it mother of medicine and mother of all diseases. And the manifestation, we know they are from head to toes, including micro and macrovascular complication. But on the part of electrolyte impairment, diabetes mellitus is a common cause of hypomagnesemia through urinary loss, especially people who are insulin dependent. So insulin dependent diabetics are the result of urinary magnesium loss along with glycosuria. If you have a excessive glycosuria and ketonuria, and you will also find these are the patients who are losing magnesium through their kidneys, and they have a clinical manifestation of hypomagnesemia. In diabetes, 70% of patients of diabetic ketoacidosis, they have also reported to have hypomagnesemia, and incidence increases in 50% over the first 12 hours after admission. So these are the patients who have diabetes insipidus. They present with the DKA. They also have hyperglycemia, uh, fluid deficiency, usually 4 to 6 liters of body deficient of fluid, and they once they are started on normal saline and insulin infusion, they are also given potassium, because insulin itself cause hypokalemia, because there is an extracellular shift into the intercellular plasma, potassium drops, and along with hypomagnesemia. So very important practical point when you are treating the patient with DKA, and be aware of associated electrolyte impairment, especially potassium and magnesium. As I told you, acute coronary syndrome, acute myocardial infarction, hypomagnesemia has been reported in 80% of patients with acute myocardial infarction, and that is the one of the cause of arrhythmias. Patients who die of acute MI with sudden cardiac death, they usually have electrolyte impairment, and they have cardiac arrhythmia because of underlying hypomagnesemia. And torsades pondus is a electrolyte impairment, that is you have a changing electrical activity, and the patient die because of acute MI because of tachyarrhythmias. But the exact mechanism is not clear. Okay, so if you have a magnesium deficiency, what are the clinical manifestations? We have discussed what is the magnesium role in metabolism of a cell, and what are the precipitating factors which can lead to hypomagnesemia. Okay, now we'll discuss what are the clinical manifestations. What is the symptomatology of patients who have a hypomagnesemia? So no specific clinical manifestation. Usually patients who have hypomagnesemia, usually they have accompanied potassium, hypokalemia, hypophosphatemia, and hypocalcemia. So these electrolyte impairment are usually in combination. Like patient with the hypomagnesemia may have associated hypokalemia, hypophosphatemia, and hypocalcemia. So hypokalemia is reported in 40% of patients with hypomagnesemia. So if you have a magnesium deficiency or potassium deficiency, they usually 40% of patients have associated other electrolyte impairment, and hypokalemia that accompanying magnesium depletion can be refractory to potassium replacement therapy, because hypokalemia, if it is corrected without magnesium replacement, it is have a no positive effect. So you have to check each electrolyte, and checking whether it is a single electrolyte impairment or it is a combination of electrolyte impairment to replace according to their deficiency. So magnesium replacement is often necessary before the hypokalemia can be corrected. So it's a very practical point important here is, if you have a patient with DKA, a patient with the diarrhea, a patient with other diseases, acute MI, and patient have any arrhythmias or any kidney disease, patient on diuretic therapy, or patient who are on digitalis and other drugs or antibiotics like gentamicin, tries to check their electrolytes balance, especially checking their potassium, phosphate, calcium, and magnesium. So correction of each electrolyte is important as they have a synergistic effect, and if you don't correct as a potassium without magnesium replacement, and that is not going to correct your electrolyte impairment. So hypocalcemia can cause hypocalcemia as a result of impaired parathyroidism. We know hypocalcemia can be a cause of hypoparathyroidism, and hypocalcemia from magnesium depletion is difficult to correct unless magnesium deficiencies are corrected. So this is again a critical point. If you have a patient with hypocalcemia, whether it is a part of primary hypoparathyroidism or it is part of a chronic kidney disease with the loss of activation of cholecalciferol in the kidneys, and that cause hypocalcemia, and at the same time you have to check their magnesium level, because without magnesium the hypocalcemia is not to be corrected. Hypophosphatemia, phosphate depletion is a cause rather than effect of magnesium depletion. So mechanism enhanced by magnesium excretion. So what are the complications of once you have a hypomagnesemia arrhythmia? As I told you, especially patients who have magnesium deficiency, they will depolarize cardiac cells and promote a tachyarrhythmia. So these are the patients who have hypomagnesemia, especially during acute coronary syndrome or acute MI. They die of tachyarrhythmia because of electrolyte impairment, and their heart become unstable and they have a tachyarrhythmias, and maybe most important of these is torsade de Pontes and VTVF. Magnesium deficiency will magnify the digital effect. Patients who are on digoxin for chronic heart failure, or atrial fibrillation, or cardiomyopathies, they are the patient who can have a digital effect leading to hypomagnesemia and promote the cardiac toxicity of the digoxin. IV magnesium can suppress the digital toxic arrhythmias. IV magnesium can also cause the refractory arrhythmias. So these are the patients who have tachyarrhythmias, especially patients on digoxin, and patients who have acute MI having tachyarrhythmia. They collapse and try to check their magnesium levels, is sodium, potassium, calcium, magnesium, and tries to correct along with anti-arrhythmic drugs. So one of the serious arrhythmia associated with the magnesium depletion is torsade de Pontes. Torsade de Pontes is a changing electrolyte, changing the electrical activity of the heart, and you will see a patient suddenly collapse because of tachyarrhythmia. And hypermagnesium is associated with the increased incidence of even atrial fibrillation. Neurological manifestation, especially patients who have hypomagnesemia, as I told you, patients who are in ICU care, and they can have altered mentation, generalized tonic-clonic seizures, they can have tremors, and hyperreflexia, or even myoclonic jerks. So these are the patients who have a CNS hyperactivity leading to fits, tremors, and hyperreflexia. So all of uncommon non-specific have a little diagnostic value, but you have to check their underlying electrolyte imbalance like hypocalcemia and or hypomagnesemia. So the clinical manifestation is characterized by ataxia. Patient may have slurred speech, may have metabolic acidosis, excessive salivation, diffuse muscle spasm, and generalized seizures. And these are the clinical manifestations of hypomagnesemia, and clinical features are often brought out by the loud noises by body contact, and thus they are termed as reactive CNS magnesium deficiency. So reactive CNS magnesium deficiency are a patient will have CNS overactivity, whether in the form of they have tremor, they have seizures, they have hyperreflexia, and need to be checked in patients, especially who are in ICU care. Serum magnesium level is an intensive marker of magnesium depletion. So when magnesium depletion is due to non-renal factors, especially patients who have a diarrhea, GI losses, the urinary magnesium excretion is a more sensitive test to magnesium. So in that case, if you have an excess body magnesium, the kidney will try to conserve the excessive loss, because it is the renal check, which is important to maintain the normal magnesium metabolism. So this is the renal magnesium retention test that just like we have water deprivation test and other like glucose tolerance test, magnesium renal magnesium retention test is also on the same basis. And you have a patient who have a renal failure or ongoing renal magnesium wasting. Patient usually they are on 24 millimole of magnesium, that is 6 gram of magnesium sulfate into 250 ml of isotonic saline, and it is infused over 1 hour. And urine is collected for 24 hours and check the magnesium levels. If urinary magnesium level excretion is less than 12 millimole in 24 hours, that means patient have evidence of magnesium depletion, because you have replaced the magnesium and the kidneys have taken up or conserved that magnesium, and they don't let it pass away because body is deficient. So you will have a less urinary excretion of magnesium. If patient is in a magnesium normal level or excess, the urinary magnesium level will be more than 19 millimole, because body doesn't want more magnesium levels, and they are just filtered out of the kidney. So magnesium challenge test can be taken as a, just like if you check the serum iron level and check the TIBC, and you will see that TIBC will be high in patient with vitamin deficiency, iron deficiency. So this is the check. You can see a magnesium retention test. Okay, so what are the different preparations which are important in magnesium replacement? We can have oral preparations, and you can have a parenteral magnesium sulfate, which is given usually in a patient with a pre-eclampsia and eclampsia. It is magnesium sulfate. So what are the protocols of patient with giving magnesium replacement? And usually mild or asymptomatic hypomagnesemia. Usually the patient are used for serum magnesium for 1.1 to 1.4 milligram with no apparent complications. But patient with magnesium deficiency of 1 to 2 milligram per kilogram, these are the patients who are infused with 50% magnesium can be lost in the urine, and these are the patients who can be replaced with 1 milliequivalent per kilogram of the first 24 hours, and then 0.5 milliequivalent per kilogram daily for the next 2 to 3 days. But we'll talk about the magnesium sulfate replacement in patient with eclampsia and pre-eclampsia. In modern hypomagnesemia, protocol is if you have a serum magnesium less than 1 milliequivalent per liter, and you can have electrolyte impairment, you can add on 6 gram magnesium sulfate to 250 to 500 ml acetylcholine saline infused over 3 hours. So this is a moderate deficiency hypomagnesemia, giving 6 gram or 48 milliequivalent of magnesium in 250 to 500 ml normal saline over 3 hours. Then follow up, you can give 5 gram of magnesium sulfate, that is 40 milliequivalent in 250 to 500 ml over next 6 hours. So this is the usually replacement regime, which is in patient with moderate hypomagnesemia, and this magnesium replacement is continued for over 12 hours for next 5 days, and monitoring their magnesium levels. Next, if we see the life-threatening hypomagnesemia, that is the magnesium level is very low, and patient may have generalized seizures, may have cardiac arrhythmias, especially torsades contests, and these are the patients who are in a life-threatening situation, and you need to replace the magnesium in a fast IV replacement, that is you give infuse the magnesium sulfate 2 gram intravenously over 2 to 5 minutes, and then follow up with the 5 gram magnesium sulfate in 250 500 ml normal saline infused over next 6 hours. So if you have a life-threatening hypomagnesemia in the form of patient who have cardiac arrhythmias, torsades spontaneous, patient is collapsing, patient has generalized seizures, and the patient is not responding to Valium and other anti-epileptic drugs, So it is important to check their magnesium and calcium levels. And usually these are the patients who have refractory seizures. They are not responding to IV, Valium, and other sedatives or anti-epileptics. They usually have underlying hypomagnesemia and need to be checked and replace according to their deficiency, whether they have mild to moderate or severe hypomagnesemia. And in that case, severe hypomagnesemia, you have to infuse magnesium sulfate 2 gram over 2 to 5 minutes, and then replace the other 5 gram over next 6 hours, and continue this 5 gram magnesium sulfate every 12 hours over the next 5 days until you have checked their magnesium levels. So this is a very, very important practical point regarding magnesium replacement therapy, especially patient who is in hypomagnesemia crisis, patient with the uncontrolled fits, patient with uncontrolled arrhythmias, and in spite of anti-arrhythmic drugs, in spite of anti-epileptics and sedatives, patient's condition is not stabilizing. You need to check the magnesium level and replace according to their deficiency. If usually they have underlying severe magnesium deficiency and need to be replaced first 2 gram in 2 to 5 minutes, then the next 5 gram in 6 hours, and then you continue for 5 gram magnesium sulfate BD for next 5 hours. So serum magnesium levels may normalize after 1 to 2 days of IV replacement therapy, but serum magnesium level will rise after the initial magnesium bolus, but will begin to fall again within 15 minutes. So this is a very practical point. Whenever the patient who have a fits with preeclampsia or eclampsia, or patient with have acute MI with the resistant cardiac arrhythmias, or patient with fits which are not controlled on routine IV Valium and other anti-epileptic drugs, try to find out their underlying magnesium levels and calcium levels. Usually these are the patients who have severe hypomagnesemia and need to be replaced by the magnesium supplements. So magnesium retention test can be valuable for identifying the endpoint of potassium replacement therapy. So this is another practical point, whether the patient has associated potassium replacement and other replacement therapy. So for monitoring of magnesium level is very important for 4 to 5 days, because once you have a replaced magnesium, it is shifted intracellularly, and within 15 minutes or half an hour, you will see the plasma level of magnesium again falls, and you have a low magnesium level because it is an intracellular electrolyte cation. Okay, what are the anesthetic considerations? So non-specific anesthetic considerations, especially patients who have isolated hypomagnesemia, should be corrected prior to elective procedure because it's potential for causing cardiac arrhythmia. So this is another practical point for fitness of a patient who is diabetic, who is especially type 1 diabetic, patient who are on diuretics like furosemide, patients who have a history of epilepsy, patient have a history of ischemic heart disease, patient who have history of digoxin intake and other antibiotics. These are the patients who need to be assessed before anesthesia, because once they are under in surgical theater, they can have very bad cardiac arrhythmias or even fits if they have a underlying hypomagnesemia and other electrolyte impairment. So before uh, sending a patient for surgery for general anesthesia, try to check their body electrolytes, and at the same time definitely they are checked for cardiac status, they are checked for the pulmonary status, and but at the same time you should check their electrolyte balance to don't let your patient to go into any complication which can be life threatening and can be fatal for the patient. So magnesium appears to have a intrinsic anti-arrhythmic properties, cerebral protective effects, that is administered prior to cardiopulmonary bypass. So this is another practical point in cardiopulmonary bypass surgery. These are the patients who are checked for magnesium deficiency. So eclampsia and pre-eclampsia and magnesium. So eclampsia and magnesium is very important if you are working in a gynae patient, people who female who are in third trimester pregnancy and they come with pre-eclampsia, eclampsia, and they have tendency to go into generalized seizures, fits. So mild pre-eclampsia, prophylactic use is controversial, but severe pre-eclampsia, when prophylactic use of 50% reduction in progression to eclampsia, but with no neonatal or mental or maternal mortality benefits. The 25% magnesium treated women experience side effects, mainly flushing. So patients with eclampsia, they have a clear benefit on prevention of seizure recurrence as compared to diazepam and phenytoin. So these are the patients who are better replaced with magnesium rather than putting them on diazepam and phenytoins, because these are the patients who can be prevented from developing eclampsia. So recommended dose in eclampsia is 4 to 6 gram IV over 20-30 minutes, and then 1 to 2 gram over 4 or 4 grams in each buttock. You can give 4 hourly and continue for 24 hours. But usually simple regime is a patient is given first bolus of magnesium sulfate, 4 grams over half an hour, then another dose given over 6 hours, and then you replace the 4 gram BD or even 3 times daily for 2 days, 2 to 5 days until they have a magnesium level replaced, and they are delivered or through C-section or whatever method is used, because these are the patients who have high risk of getting seizures, and they can have cardiac arrhythmias. Second situation when there is excess of body magnesium. So excess body magnesium, when serum magnesium level is more than 2 milligram per liter. So it is nearly always due to excess intake of magnesium in the food, especially drugs like antacids and laxatives, and patients who have a kidney disease like chronic kidney disease who have a GFR less than 30 ml per minute. So hypermagnesemia, potassium excess, is usually seen in patients who are having renal impairment, CKD patients who have a GFR less than 30 ml per minute, or patients on magnesium containing antacids or laxatives. So iatrogenic hypermagnesemia during magnesium sulfate therapy for gestational hypertension is in the mother as well as the fetus. So another possibility of hypermagnesemia if you have a excessive replacement therapy without monitoring. So monitoring of magnesium level is very important when patient is on some drugs or some replacement therapy. So rare causes include adrenal insufficiency, hypothyroidism, rhabdomyolysis, and lithium administration. These are the rare causes of hypermagnesemia when there is a rhabdomyolysis with soft tissue injuries, the muscles are damaged, and they can have hypermagnesemia. Predisposing condition, like I told you, renal insufficiency is a very important, and another is hemolysis, because these magnesium concentration in erythrocyte is approximately 3 times greater than the serum. So our red cells are rich in magnesium, and serum magnesium is expected to rise by 0.1 millicurie of for every 250 ml of erythrocyte that lies completely. So if you have a patient who is on blood transfusion, usually what happens is when blood comes from the blood bank, it is just hanging over the drip set on the ward, and you see the red cells start rising. The color of the blood become black. That is because of the oxygen consumption and hemolysis of the red cells, and that can be a patient who are given hemolyzed blood transfusion. They can have hypermagnesemia, and they can have other complications, or they can have acute rejection, acute blood transfusion reactions. So be aware of this complication of hemolysis when blood is just hanging on in the ward, and it is delay in transfusion, and the red cell they are lysed out, and there is a risk of hyperkalemia, hypermagnesemia, and other complications. So blood replacement therapy should be very careful in a to prevent the apart from the blood transfusion reactions. If you have transfusion of hemolyzed blood, that can cause hyperkalemia and hypermagnesemia. Okay, so clinical features we discussed about when you have a threshold magnesium, and when magnesium is more than 4 millicurie per liter, you can have hyporeflexia. If you have a deficiency, you will have hyperreflexia, the muscle become irritable, CNS become hyper CNS syndrome, and they can have fits. But if you have a high magnesium level, you will have a hyporeflexia when the magnesium is more than 4 millicurie per liter. If it is more than 5 millicurie per liter, you can have first degree heart block, and 10 millicurie you can have complete heart block, and above 13 it is not compatible with life. You can have cardiac arrest. Same is the with hyperkalemia. You will have AV block. You will have cardiac arrhythmia, bradyarrhythmia. Then you have a first you will have hyperacute T wave in hyperkalemia. Then you will have rod complex, QRS complex, and then you will have a sine wave. Then you have a cardiac arrest. So above 7 potassium is incompatible, and above 13 potassium magnesium is incompatible. You can have uh, consequences of a hypermagnesemia. Magnesium has been described in natural physiological calcium blockers, and most of the cardiovascular depression is a result of cardiac induction delays. So important practical point is whenever you have a patient on different drugs and patient with underlying diuretic therapy, patients on heart failure with the nephrotic syndrome, patient with the fluid overload, be aware of these electrolyte impairment in these patients. So symptomatic hypermagnesemia, especially typical patient with the neurological and neuromuscular or cardiac manifestations. So hyporeflexia, sedation, skeletal muscle weakness, and characteristic features. And the impair the release of acetylcholine, because what magnesium does is it impairs the release of acetylcholine and decreases the motor and plate sensitivity to acetylcholine muscles. So you will have loss of muscle activity, and patient will have hyporeflexia. So marked hypermagnesemia can lead to respiratory arrest and cardiac arrest. So all sources of magnesium intake should be stopped. What is the management? First, check their precipitating factors. If the patient on any replacement therapy, stop all the replacement therapy. Give high intravenous calcium. 1 gram calcium gluconate can temporarily antagonize the most of the effects of hypermagnesemia. So calcium as a part of the treatment of hypermagnesemia. So 1 gram of calcium is given, and then you add a loop diuretic, because we already know hypomagnesemia can be a cause of loop diuretic. So you have a condition when there is a hypermagnesemia, excess body magnesium. You want to get rid of this potassium, so use a loop diuretic. First, stabilize your cardiac activity, the cardiac complication by giving calcium gluconate, and then add on a loop diuretic with infusion of normal saline or in a 5% dextrose, enhance the urinary magnesium excretion. And hemodialysis is the next treatment of choice for severe hypermagnesemia. So if you have excessive magnesium levels, and you can have IV calcium to prevent the cardiac manifestation, and you can use a loop diuretic like furosemide in a normal saline or dextrose, enhance the magnesium, as we saw in patient with type 1 diabetes who present DKA, they have underlying hypomagnesemia. So this is the same method of getting rid of high magnesium levels. And if it is not corrected by these means like calcium, IV loop diuretic, then you can go for hemodialysis to get removal of hypermagnesemia. So what are the anesthetic considerations required? Close monitoring of ECG, blood pressure, and neuromuscular function. So potentiation of vasodilating and negative inotropic properties of this synthetic should be expected. The dosage of MBA should be reduced by 25% in patients with hypomagnesemia. A serial measurement of calcium and magnesium may be useful. So it is a very, very important critical point for patients who are going for general anesthesia for any surgical procedure, along with the cardiac and pulmonary assessment, and check their electrolyte, especially calcium and magnesium, to prevent the manifestation and toxic effects of these, either deficiency or excess of magnesium and calcium. So magnesium and its other uses, we have seen the preterm birth and fetal protection used as a tocolytic agent and attenuate the uterine contractility in vivo and vitro. So studies have shown IV magnesium to reduce the risk of cerebral palsy and ensuring preterm babies, and antenatal administration of may be considered because there is some evidence showing its neuroprotective effects in preterm neonates. So magnesium and pheochromocytoma. This is another practical point. Care of patient during surgical removal of pheochromocytoma and poses a significant aesthetic challenge. And patients who are on standard preoperative treatment includes beta blocker, alpha and beta adrenergic antagonists, especially labetalol, is given in the patient with pheochromocytoma. That is a both alpha and beta blocker. And several cases reports have been described its successful use of magnesium during pheochromocytoma crisis. So another critical point, monoamine oxidase inhibitors, drugs used in they stabilize hemodynamic by inhibition of catecholamine released from the adrenal medulla and peripheral adrenergic nerve endings, and direct blockade of catecholamine receptors and vasodilatation. Antiarrhythmic properties related to L-type calcium channel antagonism. So this is the all clinical manifestations and the toxic effects, and how we can prevent the patient from having clinical effects and preventing their complication by early checking of calcium and magnesium levels. So magnesium and asthma and chronic COPD. So magnesium-induced bronchodilation may be mediated by several pathways. We have seen in practical point, if you're working in emergency and patient who comes with the acute exacerbation of COPD and they are refractory to bronchodilator, and you are give them magnesium sulfate, and they have a bronchodilation properties and attenuation of calcium use muscle contractions, inhibition of collagen during muscle transmission, anti-inflammatory activity. So this is another practical point of giving magnesium to patients who are COPD with acute exacerbation or responding to routine bronchodilators. They can be given magnesium sulfate. Magnesium in tetanus. So this is another use of magnesium, which is seen in tetanus patient, or muscle activity is they can have photic fits, they can have even painful fits. Even these are the patients who are very sensitive to photic stimulation, painful stimuli, and even if they touch the patient, they can have they can have seizures. And these are the patients which magnesium has been used to reduce the need for mechanical ventilation and minimize the sedation, minimize the sympathetic overactivity, and associated tetanus. Magnesium sulfate in the dose of 5 grams loading dose of 2 to 3 grams per hour via infusion. So therapy guided by the patellar tendon reflex. You can check the reflexes, and if they have hyperreflexia, then they still deficient. If they have a hyporeflexia, that means they are now overdosed. So magnesium and side effects. So what are the other side effects? You can have burning sensation or pain on injection if you are given magnesium sulfate. What are the local side effects? especially people who are given IV infusion. They can induce agitation, drowsiness, nausea, headache, dizziness, muscle weakness, hypotension, and bradycardia. In eclampsia, approximately 25% patients may have flushing can take place. There is increased risk of postpartum hemorrhage and respiratory depression. Neonatal therapy, neonatal lethargy, hypotension, and rarely respiratory depression after prolonged administration for 48 hours. So these are the usually side effects which should be monitored when patients are on magnesium replacement therapy. Thank you very much. I think these are the very important practical points when magnesium replacement is given to patients, especially in patient with hypocalcemia with the magnesium replacement, patient who have hypokalemia with the magnesium replacement, and patient who have history of pre-eclampsia or eclampsia, and a patient with a COPD with acute exacerbation. So magnesium role is very important in our cell metabolism because it's one of the very large amount of intracellular cations like potassium, which has a role to play in the cell metabolism and stabilization of the cell membrane. Especially if patients who have a deficiency can have, as we discussed, the cardiac arrhythmias, acute MI, can have fits, can have other manifestations. So need to check these electrolyte impairment in patients who are in ICU care, especially people who are in intensive care units. They are being checked for their electrolyte impairment and checking for their daily replacement therapy if they are on TPN or NG feeding. So you need to be very vigilant patient on intensive care on food which are deficient of these electrolytes, especially calcium, potassium, magnesium, and zinc and copper. Some patients who have any condition like patient on diuretics, especially loop diuretics or thiazide diuretics, these are the patients who have a high risk of getting hypomagnesemia. And these are the patients who are given a combination of loop diuretic with potassium sparing diuretic that is called spironolactone is also potassium sparing and at the same time magnesium sparing that don't let the excessive wastage of magnesium from the renal tubule, and renal losses are minimized. And patient with diarrhea usually present with excessive watery diarrhea with hypokalemia, hypermagnesemia, patient lethargic, hypertensive, and in shock state, and you need to replace the magnesium levels. Another practical point, patient are going for surgical procedure to anesthesia department, and they are the patient apart from the cardiac, pulmonary, and other clinical assessment and fitness. You need to check their electrolyte, especially calcium and magnesium and potassium levels, because these are the patients who are being induced anesthesia. They can have high risk of getting the cardiac arrhythmias and respiratory problems if they have any electrolyte impairment, especially calcium, magnesium, and potassium. Other points in magnesium electrolyte impairment is patients who are on some replacement drugs, and patients who are having diabetes, patients who are COPD, patients who are going for surgical procedure. So these are the very practical points to be looked in, and before assessment is being made to don't let your patient have a complication like hypo or hypomagnesemia. So thank you very much. This was a very small topic, but I just tried to elaborate in practical terms what is the magnesium level, because it is a very important cation, which is which has a very important cofactor in enzyme reaction, especially which is involved in ATP molecule. So important magnesium level with the calcium level with potassium level, and these are the points to be considered when you are putting a patient on some drug on some other comorbidities and taken care of these electrolytes. So thank you very much. Hope you are good and fine. And from my side, Allah Hafiz.